This document was developed by the Centers for Disease Control and Prevention (CDC) to assist state, tribal, local, and territorial health departments to investigate and respond to importation and potential transmission of Oropouche virus, in addition to guidance on identifying and responding to local transmission. Information is provided to assist state, tribal, local, and territorial health departments in protecting pregnant women and their infants. This document serves as a reference for public health decision-making and is not meant to be prescriptive or comprehensive, as activities and decisions are jurisdiction and situation specific. The response activities outlined in this plan are based on currently available knowledge about Oropouche virus, its transmission, and its possible effects on during pregnancy. The CDC is available to assist state, tribal, local, and territorial partners and healthcare providers for any inquiries, consultations, or assistance with investigations. The document and activities described within will be updated as needed. Orov overview. Orov belongs to the Simbu serogroup of the genus Orthobunyavirus in the Peribunyaviridae family. The virus was first detected in 1955 in Trinidad and Tobago and is endemic in the Amazon basin. Previous disease activity and/or outbreaks have been described in Argentina, Bolivia, Brazil, Colombia, Ecuador, French Guyana, Panama, and Peru. One child was infected in Haiti in 2014. The current outbreak is occurring in endemic areas and new non-endemic areas outside the Amazon basin. As of August 2024, countries reporting locally acquired, autochthonous cases include Bolivia, Brazil, Colombia, Cuba, and Peru. Travel-associated cases have been identified in the United States and Europe associated with travel to Cuba or Brazil. Sylvatic enzootic transmission of OROV occurs in forested areas between mosquitoes and non-human vertebrate hosts, Exempli sloths, and non-human primates. Other vertebrates have been identified as having antibodies against OROV, such as domestic and wild birds and rodents, but their role as amplifying hosts is unknown. Humans can become infected while visiting forested areas and are likely responsible for introducing the virus into urban environments as they develop sufficient viremia to serve as hosts. Biting midges, Culicoides paraensis, and possibly certain mosquitoes, Culex quinquefasciatus, transmit the virus from an infected person to an uninfected person. Approximately 60% of people infected with OROV become symptomatic. The incubation period is typically less than 1 week, range 3 to 10 days. Initial clinical presentation is similar to diseases caused by dengue, Zika, and chikungunya viruses, with acute onset of fever, chills, headache, myalgia, muscle aches, and arthralgia, joint pain. Other symptoms can include retroorbital eye pain, photophobia, light sensitivity, nausea, vomiting, diarrhea, fatigue, maculopapular rash, conjunctival injection, bloodshot eyes, and abdominal pain. Early clinical laboratory findings can include lymphopenia and leukopenia, elevated C-reactive protein, and slightly elevated liver enzymes. Initial symptoms typically resolve after a few days, but a high proportion, about 70%, experience recurrent symptoms days to weeks after resolution of their initial illness. Although illness is typically mild, it is estimated less than 5% of patients develop hemorrhagic, bleeding, manifestations, Exempli epistaxis, nosebleed, gingival bleeding, melena, black stools, menorrhagia, heavy menstrual bleeding, petechiae, or neuroinvasive disease, Exempli meningitis, meningoencephalitis. Neuroinvasive disease symptoms may include intense occipital pain, dizziness, confusion, lethargy, photophobia, nausea, vomiting, nuchal rigidity, neck stiffness, and nystagmus, uncontrolled eye movement. Clinical laboratory findings for patients with neuroinvasive disease include pleocytosis and elevated protein in cerebrospinal fluid. People exposed to biting midges or mosquitoes infected with the virus are most at risk for developing disease. Risk factors for more severe ORV disease are not well defined, but likely include those at risk. For severe disease from other arboviruses, exempli gratia, people aged 65 years or older, or those with underlying medical conditions, such as immune suppression, hypertension, diabetes, or cardiovascular disease. Earlier this year, Brazil reported 2 deaths in otherwise healthy non-pregnant women and 5 cases in pregnant women with evidence of vertical transmission of the virus to the fetus associated with fetal death or congenital abnormalities, including microcephaly. This was the first report of deaths in Orof. Vertical transmission and associated adverse birth outcomes. Since the outbreak in Brazil peaked in January and February of 2024, additional reports of adverse birth outcomes are expected as pregnant women with exposure to ORV during the outbreak approach full term. No specific antiviral treatments or vaccines are available for ORV disease. Treatment for symptoms can include rest, fluids, and use of analgesics and antipyretics. Acetaminophen is the preferred treatment for fever and pain. Aspirin and other nonsteroidal anti-inflammatory drugs should not be used to reduce the risk of hemorrhage. Patients who develop more severe symptoms should be hospitalized for close observation and supportive treatment. Pregnant women with laboratory evidence of ORV infection should be monitored during pregnancy, and live-born infants should be carefully evaluated. Investigating suspect ORV disease cases. CDC encourages assist state, tribal, local, and territorial health departments to investigate all patients with suspected ORV disease. The goal of the investigation is to confirm that a case meets clinical criteria of a suspect case, to ensure samples are obtained and sent for testing at the CDC, and to determine potential exposures. Exempli gratia, recent travel, resides in an area with other cases or association with known ORV disease cases. Information collected during the initial investigation of a suspect case should be shared between public health and vector control programs and used to inform coordinated public health action, exempli gratia, vector control efforts, and public health communication. Assist state, tribal, local, and territorial health departments can use their standard Arboviral case report forms for the collection of symptom and exposure data. Because clinicians are integral to the surveillance process, health departments should take steps to increase healthcare provider awareness of ORV and ensure testing of suspect cases. Suspect case definition. A suspect case is a patient who has been in an area with documented or suspected ORV circulation within 2 weeks of initial symptom onset, as patients may experience recurrent symptoms and the following: abrupt onset of reported fever, headache, and one or more of the following: myalgia, arthralgia, photophobia, retroorbital/eye pain, or signs and symptoms of neuroinvasive disease. Exempli gratia, stiff neck, altered mental status, seizures, limb weakness, or cerebrospinal fluid pleocytosis, and tested negative for other possible diseases, in particular dengue, and absence of a more likely clinical explanation. If concern exists for local transmission in a non-endemic area, consider if the patient shared an exposure location with a person with confirmed ORV infection, lives in an area where travel-related cases have been identified, or has known vector exposure, exempli gratia, mosquitoes, or biting midges. If strong suspicion of ORV disease exists based on the patient's clinical features and history of travel to an area with virus circulation, do not wait on negative testing before sending specimens to CDC. Other diagnostic considerations. In many countries, outbreaks of dengue are occurring in areas with reported ORV transmission. For patients with suspected ORV disease, it is important to rule out dengue virus infection because proper clinical management of dengue can improve health outcomes. Other diagnostic considerations include chikungunya, Zika, leptospirosis, malaria, or infections caused by various other bacterial or viral pathogens. Exempli gratia, rickettsia, group A streptococcus, rubella virus, measles virus, parvovirus, enteroviruses, adenovirus, myrovirus. Laboratory testing. Specimen types. Testing eligibility. To assist state, tribal, local, and territorial partner guidance and assay availability. Laboratory testing. Laboratory diagnosis is generally accomplished by testing serum. Cerebrospinal fluid can also be tested. In patients with signs and symptoms of neuroinvasive disease, assist state, tribal, local, and territorial partners are encouraged to review and keep current on CDC's evolving OROV testing and reporting guidance. Currently, testing is limited to those meeting the suspect case definition, unless an assist state, tribal, local, and territorial health department requests an exception. Current testing is limited to assays listed in CDC's Infectious Diseases Laboratory Test Directory. Interim case definitions. OROV disease is not currently a nationally notifiable condition. CDC is working with the council or state and territorial epidemiologists, CSD, to provide guidance for OROV case reporting. Interim case. Definitions have been established for immediate voluntary reporting of OROV cases to ARBONET, the National Arboviral Disease Surveillance System. Of note, the interim case definition for non-congenital Oropouche virus disease incorporates additional assays and testing on specimen types that may become available in the future. Please refer to reporting cases to ARBONET for up-to-date guidance. Confirmed case. A case that meets the suspect case definition and one or more of the following laboratory criteria: isolation of virus from or demonstration of specific viral antigen or nucleic acid in tissue, blood, cerebrospinal fluid, or other body fluid. Fourfold or greater change in virus-specific quantitative antibody titers, impaired sera. Virus-specific IgM antibodies in cerebrospinal fluid or serum with confirmatory virus-specific neutralizing antibodies in the same or a later specimen. Probable case. A case that meets the suspect case definition and one of the following laboratory criteria: virus-specific IgM antibodies in cerebrospinal fluid or serum. Virus-specific neutralizing antibodies in a single cerebrospinal fluid or serum specimen. Pregnancy and birth defect surveillance. Based on limited data from Brazil, vertical transmission of Oropouche virus is possible. However, it is not known how frequent vertical transmission occurs during pregnancy, and if the timing of Oropouche virus disease during pregnancy increases the risk of an adverse outcome. CDC is ready to assist state, tribal, local, and territorial health departments with protecting and educating pregnant women at risk because of travel-associated or local biting midge or mosquito-borne transmission of Oropouche virus. Assist state, tribal, local, and territorial health departments are encouraged to track cases of Oropouche virus disease during pregnancy, linked to data sources with pregnancy outcomes, exempli gratia, spontaneous abortions, stillbirths, and congenital anomalies, and live-born infant outcomes, and assist with provider outreach and education. CDC encourages assist state, tribal, local, and territorial partners to consider enhanced surveillance efforts to monitor longitudinally pregnancies and their infants, such as through SetNet, surveillance for emerging threats to pregnant people and infants. Recommendations to prevent infections among travelers to areas at risk for Oropouche virus. All assist state, tribal, local, and territorial health departments should advise their residents who might travel to areas at risk for Oropouche virus circulation on how to prevent becoming infected. Exempli gratia, use of insect repellent. Specific outreach should be considered to travel medicine and other healthcare providers located in areas where a high probability of travel-associated cases can be expected based on international travel patterns of community residents. Assist state, tribal, local, and territorial health departments should work to inform the public and healthcare providers on how to prevent, diagnose, manage, and report suspected Oropouche virus cases. Specific recommendations include: public Travelers to areas with a risk of Oropouche virus transmission should protect themselves against insect bites during and for 3 weeks after travel to prevent further spread of the virus and possible importation into the United States. When used as directed, Environmental Protection Agency registered insect repellents are proven safe and effective, including for pregnant and breastfeeding women. Use Environmental Protection Agency registered repellents labeled for flies, biting flies, or culicoides. Pregnant travelers should discuss travel plans, reasons for travel, steps to prevent insect bites, and potential risk with their healthcare provider. Pregnant women considering travel to countries with an Oropouche virus level 2 travel health notice should reconsider non-essential travel. If travel is unavoidable, pregnant travelers should strictly follow Oropouche virus prevention recommendations to prevent insect bites during travel. Healthcare providers. Consider and discuss possible Oropouche virus testing with your assist state, tribal, local, and territorial health departments for travelers who meet the suspect case definition. Inform pregnant women of the possible risks to the fetus when considering travel to areas with reported Oropouche virus transmission and to counsel these patients to consider the destination, reason for traveling, and their ability to prevent insect bites. Advise people to reconsider non-essential travel to areas with an Oropouche virus level 2 travel health notice during pregnancy. If a pregnant woman decides to travel, counsel them to strictly prevent insect bites during travel. Report all suspected Oropouche virus disease infections to your assist state, tribal, local, and territorial health department to facilitate diagnosis and mitigate risk of local transmission. For after-hours contact information for health departments, please visit. Please follow standard procedures for reporting during normal business hours. Travelers with symptoms compatible with Oropouche virus disease. Seek medical care and tell their healthcare provider when and where they traveled. Do not take aspirin or other nonsteroidal anti-inflammatory drugs. Exempli gratia, ibuprofen, to reduce the risk of bleeding. Prevent insect bites during the first week of illness to avoid further spread, especially in areas where biting midges or mosquitoes are active. Responding to travel-associated Oropouche virus case. Recommended actions for areas with suspect travel-associated cases. For suspect travel-associated cases, the level of public health intervention will depend on several factors. When the case returned from an area with Oropouche virus transmission relative to their symptoms onset. Presence of potentially competent vectors in the area where the case resides. Ability of suspect case to avoid vector bites. Climatic variables, exempli gratia, season, and jurisdictional assessment of the need and capacity to respond. If the returning traveler became ill while traveling and arrives back to the United States more than 7 days after their initial illness onset, investigation into possible subsequent local transmission would typically not be warranted, as data suggest most persons do not have culturable virus in their blood beyond the first week, including during possible recurrence of symptoms. However, if the person is immunocompromised, consider whether additional investigation is warranted based on their underlying condition and likelihood of prolonged viremia. CDC is currently investigating the potential vector competence of domestic biting midge and mosquito species to determine the most likely vectors to transmit the virus in the United States. Based on the current understanding of vectors previously implicated in transmission, many United States could have vectors capable of transmitting the virus in areas of their state. If the infected traveler is returning during a period when vectors are not active in their region, that is, winter, then there is limited to no risk. In response to a suspect travel-associated case, assist state, tribal, local, and territorial health departments in collaboration with vector control programs should consider if public health interventions or messaging is warranted based on the initial case investigation and index of suspicion of the risk of subsequent local transmission. Assist state, tribal, local, and territorial health departments should communicate potential infection zones to public, vector control, and healthcare providers. Messaging and interventions could include public Advise people in the local area to protect themselves against insect bites and to seek care if they develop symptoms. When used as directed, Environmental Protection Agency registered insect repellents are proven safe and effective, including for pregnant and breastfeeding women. Advise people in the local area to use screens in windows and doors, repair screens that have tears or holes in them, and keep doors to the outside closed to prevent insect bites. Biting midges can be excluded using mesh window screens 20 or 20 by 20 mesh, that is 20 openings in 1 linear inch. Healthcare providers. Consider and discuss possible Oropouche virus testing with assist state, tribal, local, and territorial health departments for individuals who meet the suspect case definition. Report all suspected Oropouche virus disease infections to your assist state, tribal, local, and territorial health department to facilitate diagnosis and mitigate risk of local transmission. For after-hours contact information for health departments, please visit. Please follow standard procedures for reporting during normal business hours. Suspect travel-associated cases. Advise to avoid biting midge and mosquito bites for the first week of their illness, and any travel companions who are asymptomatic should avoid biting midge bites or mosquito bites for 3 weeks after travel, to account for potential incubation period and any viremic phase. Recommended actions for areas with probable or confirmed travel-associated cases. If a travel-associated case patient has laboratory evidence of recent Oropouche virus infection, the local jurisdiction should assess the likelihood of local transmission based on the factors used to assess a suspect travel-associated case. Exempli gratia, timing of illness onset relative to travel and presence of vector and supportive climatic factors. Based on the assessment of potential risk, measures noted above should be considered and potentially implemented if there is concern for local spread. Assist state, tribal, local, and territorial health departments can also consider. Inquire about any known contacts, including household occupants, who might have clinically compatible symptoms. If any are noted, attempts should be made to obtain a sample and determine the contact's history of travel and type of contact with the confirmed or probable travel-associated case. If public health and vector control program officials determine there is an increased risk of local transmission based on the timing of illness onset relative to travel and presence of vector and supportive climatic factors, the following activities could be considered. Conduct event-based surveillance for fever of unknown origin. Educate providers to be vigilant for unexplained clusters of febrile illness and to report the finding to public health. Implement syndromic surveillance in healthcare facilities in and around the area of concern. Sample houses around the case patient's household or other likely exposure location to determine if there are any other individuals who have had recent symptoms compatible with Oropouche virus disease. If anyone is found to have compatible symptoms, obtain specimens for Oropouche virus testing and refer for clinical care. The geographic scope and intensity of the surveillance will depend on local circumstances, such as population density, potential vector abundance, number and locations of travel-associated cases, and other risk factors. Exempli gratia, lack of air conditioning or screens. CDC is available to provide additional guidance to assist state, tribal, local, and territorial health departments as requested. Distribute information on vector bite prevention, exempli gratia, door hangers, pamphlets on personnel protective measures in the area of the travel-associated disease case patient's household. Consider using social media, TV, radio, newspapers, and other media outlets to distribute information on bite prevention. Consider conducting vector surveillance activities such as setting traps, identifying potential vectors to species, and when appropriate, conducting real-time reverse transcription polymerase chain reaction testing. Consider conducting vector control activities such as identifying potential infection zones, applying insecticides, and conducting door-to-door inspections for vectors when appropriate. Assessing for potential local Oropouche virus transmission. For all suspect cases, Investigators should inquire about recent travel and attempt to identify other cases by inquiring about other symptomatic persons in the same place of residence, that is, household, shelter, etc., and recommend testing of symptomatic individuals that meet the suspect case definition. During case investigations, persons with suspected Oropouche virus infection and their household members should be provided directions to prevent further transmission, identify and eliminate possible vector habitats around the household, that is, water holding containers, and instructions on when to seek additional care or testing if symptomatic. Investigators should determine whether the suspect case has visited an area with active Oropouche virus transmission. If a confirmed or probable case is thought to be locally acquired, the transmission route should be thoroughly investigated. Investigators should determine if biting midges, Culicoides species pluralis, or mosquito, Culex quinquefasciatus, vectors that transmit Oropouche virus have been documented in the area, and inquire about other less common modes of non-vector-borne transmission, such as transmission through recent receipt of blood, organ, or tissues, or through occupational exposure, exempli gratia, needle stick or mucosal exposure to Oropouche virus in a hospital or laboratory. Sexual transmission should also be considered, but has not been documented as a route of Oropouche virus transmission. To assess for possible sexual transmission, investigators should inquire about the recent sexual contacts, vaginal, anal, or oral, use of condoms or other barrier methods, and partner travel history and symptom status. A confirmed case of local vector-borne transmission is defined as a person without any travel to an area with Oropouche virus circulation or other known exposure to potentially infected blood, organs, or tissues, and who meets the interim confirmed case definition. Once a locally acquired case is confirmed, follow recommendations outlined in the next section. A jurisdiction may decide to implement the recommendations when a probable case is identified and no further testing is possible, and the clinical presentation and available test results, other exposures, and local epidemiology indicate there is the possibility of local transmission. Responding to local Oropouche virus transmission. Local transmission by vectors should be assumed, if it is seasonally appropriate, whenever a case is confirmed and other routes of exposure, exempli gratia, travel, transfusion, sex, laboratory exposure, have been evaluated and ruled out. Under these circumstances, assist state, tribal, local, and territorial health departments should implement surveillance for Oropouche virus disease around the home of the confirmed, locally acquired case and any other likely sites, exempli gratia, work or recreation, of transmission identified through the case investigation. The principal objectives of this surveillance should be to define the frequency and geographic extent of local transmission. Confirmed local transmission. In response to a single case of local vector-borne transmission, assist state, tribal, local, and territorial health departments should coordinate with CDC and other agencies and authorities regarding local Oropouche virus transmission event and response. Identify the physical location of the case patient's most likely places of exposure, exempli gratia, home, work, other United States location if recent travel. Implement targeted epidemiologic surveillance activities in suspected areas of local transmission to identify additional cases, including implement targeted epidemiologic surveillance activities in suspected areas of local transmission to identify additional cases, including assess other household members for symptoms of Oropouche virus disease and collect serum to test for recent Oropouche virus infection. Consider a house-to-house survey of neighborhood households, workplaces, or other likely exposure locations to identify any recently symptomatic people and, if symptomatic, obtain specimens to test for recent Oropouche virus infection. As stated in Section 5.2, the geographic scope and intensity of enhanced surveillance will depend on local circumstances. CDC is available to provide additional guidance to assist state, tribal, local, and territorial health departments as requested. Consider implementing syndromic surveillance in healthcare facilities in and around the area of concern. Assess the need for vector control and surveillance measures, which could include using case report data to determine infection dates and potential infection zones. Intensify vector control and surveillance in the identified geographic areas, which may include focal or area-wide application of insecticides, door-to-door inspections, and source reduction, that is, removal or modification of biting midge or mosquito larval habitats. Given the importance of identifying the vectors responsible for transmission, consider vector testing in the immediate areas around cases, that is, residence and place of work. Develop standing communication channels with vector control leads/officials to share vital information and coordinate surveillance and vector control efforts. Communicate with blood and tissue collection establishments. Provide testing guidance to the public and healthcare providers, including those who care for pregnant women. Prepare and issue a media statement in coordination with CDC and involved local health departments. Hold press conferences/events about confirmed local transmission, ongoing investigations, and updates. Augment clinician outreach and communication activities to healthcare providers in the county or jurisdiction through existing local channels for urgent infectious disease alerts. Exempli gratia, messages through local medical societies and local chapters, health alert network messages, conference calls. Consider implementing enhanced surveillance for persons presenting to clinical care with clinically compatible illness. Communicate with clinicians caring for pregnant women and infants about the risks of Oropouche virus and disseminate CDC guidance for these populations. Ensure that state and local maternal and child health and birth defects programs are integrated into Oropouche virus planning and response activities. Provide information to pregnant women and persons of reproductive age about the presence of Oropouche virus in the local area and what precautions they should take to prevent being infected with or avoid Oropouche virus exposure during pregnancy. Voluntarily report the case to Arbonet using interim case definitions. Monitor local news stories and social media posts to determine if information is accurate, identify messaging gaps, and adjust communication materials as needed. Implement community outreach efforts by adapting pre-developed messages to encourage care seeking and testing for confirmation, when appropriate, of people with clinically compatible illnesses. Ensure engagement of public health, clinical, and community organizations to socialize and implement response plans. Confirmed local transmission involving more than one case. The definition of multi-person local transmission is based on a limited understanding of potential vectors in the United States and is subject to change as more is learned. At this time, multi-person local transmission should be suspected when two or more probable or confirmed cases, without travel history to areas with known virus circulation, occur in different households or workplaces located within 1 mile of each other and have less than 45 days between onset of their illness, which is approximately the length of 3 incubation periods in humans and insect vectors. If a common exposure within a mile cannot be identified or the illness onset for the cases is greater than or equal to 45 days apart, those cases can be considered individual confirmed local cases. If a assist state, tribal, local, and territorial health department has concerns about suspected multi-person local transmission that does not meet this definition. For confirmed multi-person local transmission, the level of public health intervention will depend on multiple factors. Number of cases identified in the community, abundance of competent vectors, and characteristics and size of risk area, that is, population density, urban versus rural, proximity to neighboring communities, and geographic features. In response to a suspected multi-person local transmission event for Oropouche virus, assist state, tribal, local, and territorial health departments should in coordination with CDC, define geographic areas with Oropouche virus transmission risk and the need for vector control activities. Prepare and issue a media statement in coordination with CDC and involved local health departments. Intensify efforts to determine the risk of ongoing local transmission and adjust the geographic areas for public health interventions as necessary. If indicated by available epidemiologic, entomologic, and environmental information, the identified geographic areas may be expanded or reduced with consideration of other factors. Continue and possibly expand epidemiologic surveillance activities as described in Section 7.1. Confirmed local transmission to identify other possible cases of local transmission. Continue vector control and surveillance measures as guided by the entomologic evaluation of the area. Recommend testing of pregnant women and other people meeting the suspect case definition who live in or travel to the impacted area. Implement expanded jurisdictional intervention plans for reducing risk and target messages for all vulnerable populations, specifically pregnant women, persons at risk for unintended pregnancy, persons who choose to delay or avoid pregnancy during the outbreak, persons planning pregnancy, and individuals with an increased risk of vector exposure, exempli gratia, unhoused and outdoor workers. Identify statewide resources for caring for infants and children with Oropouche virus-associated birth defects, developmental concerns, and other related outcomes. Encourage providers to keep abreast of recommendations and advisory updates from the American College of Obstetricians and Gynecologists, Society for Maternal and Fetal Medicine, and American Academy of Pediatrics. Communicate with blood and tissue collection establishments regarding risk areas. Conduct risk communication activities with CDC assistance that ensure information and prevention recommendations reach intended audiences within their jurisdictions, including people who live in, work in, or plan to travel to the area where transmission is thought to be occurring, as well as to other relevant stakeholders, exempli gratia, laboratories, healthcare partners/providers, blood and tissue collection establishments, neighboring states, tribal leaders. Communication activities should describe the area where Oropouche virus transmission is thought to be occurring based on the best available epidemiologic, entomologic, and environmental information. Identify an estimated date when local transmission began. Describe all surveillance and response efforts taking place in the affected area. Provide objective assessments of the situation and scale of the public health threat. Provide advice about ways to reduce mosquito and biting midge populations around the home. And provide guidance to laboratories as needed. Engage early with businesses, including blood and tissue collection establishments, and labor stakeholders to prepare for the potential short and long-term effects, exempli gratia, economic, infrastructure, supply. Provide recommendations for employers with work sites in a designated area. Provide recommendations for travelers going to and from affected areas, exempli gratia, whether to avoid travel. Voluntarily report cases to Arbonet using interim case definitions. Continue to monitor the status of local transmission on, at a minimum, a weekly basis. The geographic area's Oropouche virus intervention should be adjusted based on current information. Environmental conditions not conducive to biting midge or mosquito activity or other evidence, exempli gratia, more than 45 days without a case, that indicates the risk of Oropouche virus transmission has been reduced, should also be considered when scaling down interventions. Implement a protocol and communication strategy when interventions are changed. Other considerations. Assist state, tribal, local, and territorial health departments may consider utilizing wastewater surveillance as an adjunct to other surveillance approaches previously described. Wastewater surveillance may have the potential to aid in determining whether there is a risk of disease transmission in their communities. The limitations of the approach include inability to inform whether local transmission is occurring because virus detection cannot distinguish between the presence of travel-associated cases or locally acquired cases in the community. The duration of viral shedding in infected individuals is unknown. This would limit the usefulness of the approach in determining ongoing risk. And since the limit of detection for Oropouche virus is not established, negative findings may not indicate the absence of infections in the community. Epidemiology. Appendix A. Estimated range of potential vectors. Distribution of Culicoides paraensis and Culex quinquefasciatus in the United States and select territories based on field observations and modeling. Presence of vectors in a jurisdiction does not imply uniform distribution throughout the entire geographic areas. These maps will be updated as more is learned about the specific vectors that contribute to transmission in United States and territories in the Americas. There is a zone where Culex quinquefasciatus hybridizes with other Culex species. This is not accounted for in the map because there have been no vector competence studies on these species. Culicoides paraensis. Geographic distribution in the United States and territories. Red shaded areas indicate presence of Culicoides paraensis, a biting midge species known to transmit the Oropouche virus. United States with confirmed presence: Texas, Louisiana, Mississippi, Alabama, Georgia, Florida, South Carolina, North Carolina, Tennessee, Arkansas, Missouri, Illinois, Indiana, Kentucky, and Virginia. Territories with confirmed presence: Puerto Rico and United States Virgin Islands. Not present: Hawaii, not shaded. Culex quinquefasciatus. Geographic distribution in the United States and territories. Orange shaded areas indicate confirmed presence of Culex quinquefasciatus, a mosquito species known to transmit diseases such as West Nile virus, lymphatic filariasis, and St. Louis encephalitis. Regions with presence: southern half of the continental United States, Hawaii, Puerto Rico, and United States Virgin Islands. Regions without presence: northern states, not shaded. Appendix B. Recommendations for entomological surveillance. Below are interim recommendations until vector competence work is completed to inform more specific guidance for the United States and Puerto Rico. Published literature that reports work using strains of Oropouche virus circulating prior to 2024 and field detections of infected vectors indicates the primary vectors are Culicoides paraensis and Culex quinquefasciatus in areas where outbreaks have occurred in South America. Surveillance for potential vectors of Oropouche virus should include: 1. Trapping of biting midges and mosquitoes. 2. Identification of vectors to species and when warranted. 3. Pooling of vectors for PCR testing. Trapping. Biting midges, Culicoides, SPP. There are commercially available traps sold by John W. Hawk that are designed to attract and contain biting midges. CDC miniature light traps that are commonly used in mosquito control programs can be used to sample biting midge populations. The holding chambers utilize screening or netting designed to contain mosquitoes, but biting midges can escape through the mesh. Modifications can be made by replacing netting and/or screening with a finer mesh material. Appendix D provides instructions on how to make these modifications. Host-seeking female biting midges are attracted to carbon dioxide. Use of carbon dioxide in the vicinity of the trap will increase the likelihood of collecting biting midges. Mosquitoes, Culex quinquefasciatus. The American Mosquito Control Association has published best practices for surveillance of mosquitoes, including Culex mosquitoes in continental United States. Virtual training for best management practices in integrated mosquito management can be accessed here. American Mosquito Control Association's Best Practices for Integrated Mosquito Management Virtual Training Program. CDC guidance developed for surveillance of West Nile vectors, specific for adult Culex quinquefasciatus, is provided below. Specimen collection and traps. Light traps collect a wide range of mosquito species, providing information about both primary and secondary vectors and a better understanding of the species composition in an area. Culex quinquefasciatus can be collected in light traps. CDC miniature light traps, Sudia and Chamberlain 1962, are lightweight and use batteries to provide power to a light source and fan motor. Carbon dioxide, usually dry ice, is frequently used as an additional attractant. Light traps collections may consist largely of unfed, nulliparous individuals, which greatly reduces the likelihood of detecting arboviruses. Gravid traps can be useful for sampling Culex quinquefasciatus, particularly in urban areas. Because gravid females have previously taken a blood meal, this increases the likelihood of capturing infected mosquitoes and detecting virus. Gravid traps can be baited with attractants such as fresh or dry grass clipping infusions, rabbit chow infusions, cow manure, fish oil, or other materials that mimic the stagnant water in habitats where these species lay eggs. These vary in attractiveness depending on the type of infusion and its preparation. Collecting resting mosquitoes provides a good representation of vector population structure since unfed, gravid, and blood-fed females, as well as males, may be collected. Resting mosquitoes can be collected using suction traps, such as the CDC resting trap, and by using handheld or backpack mechanical aspirators to remove mosquitoes from natural resting harborages or artificial resting structures. Exempli grazia, wooden resting boxes, red boxes, fiber pots, and other similar containers. Because of the wide variety of resting sites and the low density of resting mosquitoes in most locations, sampling resting populations is labor-intensive and sufficient sample sizes are often difficult to obtain. Identification of mosquitoes and biting midges to species. There are numerous regional and state guides, taxonomic keys, available for identifying mosquitoes in specific regions and states. The identification and geographical distribution of the mosquitoes of North America, north of Mexico, covers all mosquito species documented in North America as of 2005. For the most precise information about potential vectors, identification to species level is necessary. Some identification keys for Culicoides include a systematic review of the genus Culicoides, Diptera, Ceratopagonidae, of Virginia with a geographic catalog of the species occurring in the eastern United States north of Florida. The sandflies, Culicoides, of Florida, Diptera, Ceratopagonidae. A photographic key to the adult female biting midges, Diptera, Ceratopagonidae, Culicoides, of Florida. The West Indian sandflies of the genus Culicoides, Diptera, Ceratopagonidae. Vector testing is encouraged to identify the vectors responsible for transmission. When responding to a locally acquired case, if vector testing for Oropouche virus is not available at a local or state agency, biting midges or mosquitoes can be processed using these procedures. Preservation of specimens for nucleic acid detection. Specimens may be kept frozen at 4 degrees Celsius and or on chill tables during the sorting process. Mosquitoes and biting midges should be separated by species, collection date, and site. Once sorted, specimens should be stored at one of the following conditions until tested. Dry, frozen at -80 degrees Celsius, dry, or in 70 to 95% non-denatured ethanol, frozen at -20 degrees Celsius, and in 70 to 95% non-denatured ethanol, at 4 degrees Celsius, least preferred. Real-time reverse transcription polymerase chain reaction testing for Oropouche virus. Homogenize specimens in a buffer suitable for RNA extraction, such as cell culture media, viral transport media, or phosphate-buffered saline. Pool 1 to 50 individual specimens and add 1 milliliter homogenization buffer. Centrifuge the homogenate to separate and clarify the supernatant. Extract RNA from an aliquot of clarified supernatant using a commercially available RNA or total nucleic acid extraction kit. Use the primers, probe, and thermocycling conditions to conduct Oropouche virus real-time reverse transcription polymerase chain reaction. References. Appendix C. Vector control strategies. Below are interim recommendations until vector competence work is completed to inform more specific guidance for the United States and Puerto Rico. Published literature that reports work using strains of Oropouche virus circulating prior to 2024 and field detections of infected vectors indicates the primary vectors are Culicoides paraensis and Culex quinquefasciatus in areas where outbreaks have occurred in South America. Specific strategies for control of biting midges are currently being evaluated. There is existing guidance that targets Culex quinquefasciatus mosquitoes because of their role in West Nile virus transmission. The American Mosquito Control Association Manual of Best Management Practices that includes control of Culex mosquitoes. Virtual training for best management practices in integrated mosquito management can be accessed here. American Mosquito Control Association's Best Practices for Integrated Mosquito Management Virtual Training Program. Integrated vector management should be used to prevent and control Oropouche virus disease. Integrated vector management is a comprehensive program that applies the principles of integrated pest management. More information on integrated vector management can be found in the guidelines for West Nile virus surveillance and control. Vector control for responding to cases of Oropouche virus disease. Educate all vector control personnel involved in responding to a case of Oropouche virus disease about the disease and prevention measures. Staff going to the field should take steps to lower their risk of infection, such as wearing permethrin-treated long-sleeve shirts and pants and using Environmental Protection Agency-registered insect repellent. The basis of the strategies listed here are adapted from Florida's Lee County Mosquito Control District Response Plan and CDC's guidelines for West Nile virus surveillance and control. I'll work with epidemiologists to determine approximate infection dates and potential sites of exposure to infected vectors, exempli gratia, residence, workplace, places of recreation. Set traps to collect both biting midges and mosquitoes up to a 1-mile radius of infection zones. See Appendix B for more information on trapping and Appendix D for information on modifying CDC light trap chambers to collect both mosquitoes and biting midges. Identify a species and prepare mosquito and biting midge pools separately if Oropouche virus testing is planned. See Appendix B. Work with local public health to communicate ways that community members can assist in controlling mosquito larval habitats. Exempli gratia, disposing of discarded tires or other trash containers, emptying or treating unmaintained swimming pools. Consider messaging, exempli gratia, newspaper release, interviews, conducting town hall meeting, in collaboration with public health officials to raise awareness about the risk of Oropouche virus in the community and address questions and concerns regarding community-level vector control measures. Assist in the distribution of materials about Oropouche virus prevention, exempli gratia, door hangers, flyers, around the suspected infection site. Implement vector control measures. Most of the control measures targeting biting midges in the United States has been in the context of animal, livestock, health. Evaluation of methods to control biting midges to prevent human disease should be undertaken. Control measures can include aerial or ground adulticide using ultra-low volume technology up to a 1 square mile polygon, alternating between pyrethroids and organophosphates for subsequent applications. Ground larvicide, low-volume truck, up to a 1-mile radius around suspected site of infection, and O-barrier treatments on foliage, tree holes, fences, and other potential biting midge resting areas at least 1 acre around the suspected site of infection. All products used for larval or adult control, ultra-low volume or barrier treatments of vectors should be Environmental Protection Agency registered and labeled for the control of the target pest. Exempli gratia Culicoides or Culex mosquitoes. Conduct vector surveillance and control measures until local transmission is no longer occurring. The decisions to decrease or stop activities should be made in conjunction with assist state, tribal, local, and territorial health department and might include greater than 45 days since the illness onset of the last reported human disease case. Low. In addition to the activities outlined above, consideration should be given to other aspects of integrated vector management, including safety of vector control pesticides and practices, quality of vector control, maintaining good records of vector control efforts, and monitoring of insecticide resistance in mosquitoes. The CDC bottle bioassay is recommended to test for insecticide resistance in mosquitoes, but has not been evaluated for use on biting midges. Resistance testing should be conducted before a product is first used. Resistance testing should follow published protocols to provide standardized results. A quick resistance assessment should be conducted prior to emergency adulticiding. Insecticide resistance test kits can be requested from the CDC by sending an email to United States Botley and requesting an order form. The instruction manual for use of the CDC bottle bioassay is located here. CDC bottle bioassay, mosquitoes, and CDC. More information about integrated vector management, associated activities, legal action to achieve access or control, and continuing education can be found in the guidelines for West Nile virus surveillance and control. The CDC miniature light trap is a key tool for monitoring vectors such as mosquitoes and Culicoides species pluralis, known transmitters of the Oropouche virus. This device uses light to attract flying insects over short distances, while a battery-powered fan draws them into a collection net. When paired with carbon dioxide, typically released from dry ice, the trap significantly increases the capture of blood-seeking female insects. Its portable and efficient design makes it ideal for field surveillance, supporting epidemiological studies, species identification, and risk assessment. The CDC trap plays a vital role in integrated vector control strategies, especially in endemic areas or during outbreak investigations. Modified capture chamber for CDC miniature light trap. This modified capture chamber enhances the CDC miniature light trap for targeted collection of biting midges, especially Culicoides species pluralis, the primary vectors of Oropouche virus. The setup includes 2 collection chambers, fine mesh funnels, plastic vials, and a window screen, all designed to separate mosquitoes from no-see-ums based on size and behavior. This adaptation improves sample quality, allowing researchers to efficiently isolate and identify species of epidemiological importance. By optimizing field collection, this tool supports vector surveillance, ecological studies, and outbreak response in endemic regions. It's a practical innovation for arbovirus research and integrated vector control. Modified capture chamber for CDC miniature light trap. This step-by-step guide shows how to assemble a modified capture chamber for the CDC miniature light trap, optimized for collecting biting midges in the field. First, the cutout chamber lid is screwed onto a fine mesh funnel. Then, a plastic vial cap with its center removed is slid over the funnel's narrow end. A 50 milliliter plastic vial, cut at the bottom, is attached to the cap, creating a passage for insects. Finally, a second vial containing alcohol is inserted into the open end. This allows captured insects to be preserved immediately without handling liquids on site. The design improves field efficiency, protects delicate specimens, and supports high-quality entomological surveillance for Oropouche virus vectors. Focused on laboratory handling and preservation of mosquitoes and no-see-ums, Culicoides species pluralis, especially relevant for Oropouche virus surveillance. Mosquitoes and no-see-ums are handled and preserved differently in the laboratory due to their size and fragility. Mosquitoes are typically processed dry, allowing for easy sorting and morphological analysis. In contrast, no-see-ums, especially Culicoides species pluralis, are preserved wet, usually in isopropyl alcohol or ethanol, to maintain delicate structures. Species identification relies heavily on wing patterns of dark and pale spots, best observed in wet or slide-mounted specimens. This distinction in handling is essential for accurate vector identification and supports high-quality surveillance of Oropouche virus transmission. highlighting key resources for identifying Culicoides species pluralis, noceums, in Florida. Accurate identification of noceums is essential for vector surveillance and ecological research. Two key resources support this work in Florida. The first is a comprehensive monograph published in 1979, The Sandflies, Culicoides, of Florida, by Blanton and Worth. It covers classification, biology, distribution, and diagnostic keys across 204 pages. The second is a modern photographic key published in 2024 by Blosser and colleagues. It provides high-resolution images, seasonal data, and species-level identification for adult female culicoides. Together, these tools offer entomologists and public health professionals the foundation for precise species identification and effective vector control. Oropouche virus, what you need to know. Short educational video. Welcome to Medicina Interna, your trusted source for clear, accessible medical education in Spanish and English. In this short video, we explore the Oropouche virus, an emerging arbovirus that's rapidly gaining attention across Latin America and the Caribbean. Whether you're a medical student, clinician, public health professional, or simply curious about tropical diseases, this video offers a concise yet powerful overview of a virus that's often overlooked, but increasingly relevant. Clinical overview. Oropouche virus. Key points. Oropouche virus is transmitted mainly by biting midges and some mosquitoes. Sexual transmission may be possible, but has not yet been reported. Reported in parts of South America, Central America, and the Caribbean. In June 2024, Cuba confirmed its first case. Illness usually begins abruptly with high fever, severe headache, chills, myalgia, arthralgia. No vaccines or specific treatments are currently available. Epidemiology, Oropouche virus. Classification, member of Simbu serogroup, genus Orthobunyavirus, family Peribunyaviridae. First detection, 1955 febrile forestry worker in Vega de Oropouche, Trinidad and Tobago. Endemic region, Amazon basin. Historical outbreaks. Pre-2000, outbreaks in Brazil, Panama, Peru. Evidence of infected animals in Colombia and Trinidad. Spread in recent decades. Human cases reported in Argentina, Bolivia, Brazil, Colombia, Ecuador, French Guyana, Panama, Peru. 2014, pediatric case identified in Haiti. Recent developments. Late 2023, large outbreaks in endemic and new areas of South America. June 2024, first confirmed case in Cuba. United States, no evidence of local transmission to date. Epidemiological map. Titled Oropouche virus in the Americas, 2024. This map illustrates the geographic distribution of confirmed Oropouche virus cases across the Americas in 2024. A total of 16,239 cases have been reported, with 4 deaths, all occurring in Brazil. Brazil remains the epicenter, accounting for over 13,700 cases. Other affected countries include Peru, Bolivia, Cuba, Colombia, Panama, Ecuador, Guyana, and Barbados. Imported cases have also been documented in Canada, the United States, and the Cayman Islands. The color gradient reflects case intensity, with darker shades indicating higher transmission. Red markers highlight imported cases and fatalities. This visualization supports regional surveillance efforts and underscores the importance of coordinated response strategies for emerging arboviruses like Oropouche. Clinical features, Oropouche virus. Incubation period, 1 to 10 days. Typical onset, sudden fever, 38 to 40 degrees Celsius, severe headache, chills, myalgia, arthralgia. Other common signs. Photophobia, dizziness, retroorbital/ocular pain. Nausea, vomiting. Maculopapular rash, starts on trunk, spreads to limbs. Less common symptoms. Conjunctival injection. Diarrhea, severe abdominal pain. Hemorrhagic signs: epistaxis, gingival bleeding, melena, menorrhagia, petechiae. Course of illness: symptoms usually last 2 to 7 days. Up to 60% of patients experience relapse with similar symptoms days or weeks later. Differential diagnosis: clinical presentation may mimic dengue, chikungunya, Zika virus, or malaria. Detailed interpretation: abnormal laboratory findings. Oropouche virus infection typically presents as an acute febrile illness, and while laboratory findings are not pathognomonic, they can support clinical suspicion and help differentiate from other tropical infections. Here's a breakdown of the most commonly reported abnormalities. 1. Lymphopenia and leukopenia. Lymphopenia, low lymphocyte count, reflects viral suppression or redistribution of lymphocytes during acute infection. Leukopenia, low total white blood cell count, is common in viral illnesses and may indicate bone marrow suppression or peripheral destruction. These findings are similar to those seen in dengue and Zika virus infections and may help distinguish Oropouche from bacterial causes of fever. 2. Elevated C-reactive protein, CRP. CRP is an acute phase reactant produced by the liver in response to inflammation. Elevated CRP in Oropouche infection suggests a systemic inflammatory response, but levels are typically moderate, not as high as in bacterial sepsis. CRP can be useful in monitoring disease progression or ruling out co-infections. 3. Mild elevation of liver enzymes, aspartate aminotransferase and alanine aminotransferase. Transaminase elevation is usually mild to moderate, indicating hepatic involvement without fulminant hepatitis. This pattern is consistent with other arboviral infections and may reflect direct viral cytopathic effects or immune-mediated injury. Liver function should be monitored, especially in patients with pre-existing hepatic conditions. 4. Thrombocytopenia. A drop in platelet count has been reported in some cases, though it is less frequent and less severe than in dengue. When present, it may correlate with hemorrhagic manifestations such as petechiae, epistaxis, or gingival bleeding. Platelet monitoring is recommended in patients with bleeding symptoms or during relapse phases. Clinical relevance. These laboratory findings help differentiate Oropouche from other febrile illnesses like malaria, typhoid, or leptospirosis. Support the diagnosis when combined with epidemiological exposure and clinical presentation. May guide supportive care and monitoring, especially in vulnerable populations, pregnant women, elderly, immunocompromised. Neuroinvasive disease. Potential complications. Oropouche virus can occasionally invade the central nervous system, leading to conditions such as meningitis or encephalitis. Frequency. Estimated that up to 4% of patients develop neurological symptoms after the initial febrile illness. Reported neurological symptoms: severe occipital headache, dizziness and confusion, lethargy, photophobia, light sensitivity, nausea and vomiting, neck stiffness, nuchal rigidity, nystagmus, involuntary eye movements, cerebrospinal fluid findings, pleocytosis, increased white blood cell count in cerebrospinal fluid, indicating inflammation. Elevated proteins suggest disruption of the blood-brain barrier or inflammatory response. Clinical relevance. Although relatively uncommon, neuroinvasive disease is important to recognize because it can mimic other viral or bacterial central nervous system infections. Cerebrospinal fluid analysis is crucial for differentiating Oropouche from other causes of meningitis/encephalitis in endemic regions. Most patients recover, but close monitoring is recommended during the acute neurological phase. Guillain-Barré syndrome and Oropouche virus. Case reports. A published report described 3 patients who developed Guillain-Barré syndrome after Oropouche virus infection. Clinical course. All 3 had an acute febrile illness and tested positive for Oropouche virus by reverse transcription polymerase chain reaction. Neurological symptoms of Guillain-Barré syndrome appeared 10 to 11 days after onset of fever. Patients required hospitalization for 3 to 4 weeks, but were discharged without apparent long-term sequelae. Significance: these are the first documented cases of Guillain-Barré syndrome following Oropouche infection. Guillain-Barré syndrome is already known to be associated with other viral infections, including arboviruses, exempli gratia, Zika virus. Ongoing research. The CDC is collaborating with international partners to better understand the possible link between Oropouche virus and Guillain-Barré syndrome. Clinical relevance. Guillain-Barré syndrome is an autoimmune neurological disorder where the immune system attacks peripheral nerves, leading to weakness, paralysis, or sensory changes. Recognizing this potential complication is important for clinicians in endemic regions, especially when patients present with neurological symptoms after febrile illness. Early diagnosis and supportive care can improve outcomes, as seen in the reported cases. Diagnosis of Oropouche virus disease. 1. Preliminary diagnosis. Based on clinical symptoms, exempli gratia, acute febrile illness. Geographic exposure, travel history, residence in endemic areas. Risk activities, exempli gratia, outdoor work, exposure to biting midges. 2. Why testing is recommended. Even though there is no specific antiviral treatment, testing suspected cases helps to guide clinical management. Avoid unnecessary procedures or medications, exempli gratia, non-steroidal anti-inflammatory drugs in case of bleeding risk. Monitor for severe symptoms or complications. Advise on prevention. Avoid mosquito bites. Refrain from blood donation. Consider potential sexual transmission. Support public health surveillance. Identify areas of viral circulation. Assess risk for other individuals. Laboratory diagnosis. Viral detection. Serum samples. Virus can be cultured during the first 5 days of illness. Reverse transcription polymerase chain reaction can detect viral RNA for several days beyond that. IgM antibodies begin to form toward the end of the first week. IgG antibodies appear later and persist longer. Neuroinvasive cases. Cerebrospinal fluid. Viral RNA may be detectable, but is often absent. Serologic testing is preferred for cerebrospinal fluid samples. Other sample types. Saliva and urine. Viral RNA detected in one patient at day 5. These sample types are not validated or available for testing in the United States. CDC testing capabilities. Reverse transcription polymerase chain reaction, real-time. Detects viral RNA in serum and cerebrospinal fluid during acute phase. Plaque reduction neutralization test. Detects virus-specific neutralizing antibodies in serum and cerebrospinal fluid. Serologic confirmation. Requires paired samples, acute and convalescent. Must show a greater than or equal to 4-fold rise in antibody titers to confirm recent infection. Treatment of Oropouche virus disease. No specific antiviral medication exists. Management is based on supportive care. 1. Supportive care. Rest. Hydration, fluids. Analgesics and antipyretics for pain and fever relief. Hospitalization for patients with severe symptoms to allow close monitoring and supportive treatment. 2. Clinical considerations. Patients with suspected dengue should receive appropriate management without waiting for diagnostic test results, due to risk of rapid deterioration. Avoid medications containing aspirin or other nonsteroidal anti-inflammatory drugs to reduce the risk of bleeding complications. Safer alternative: acetaminophen for fever and pain. Prevention of Oropouche virus disease. Mosquito bite prevention. The best protection is to avoid bites from biting midges and mosquitoes. No vaccine currently exists to prevent Oropouche virus infection. Recommended measures: use insect repellents. Wear long-sleeved clothing. Sleep under bed nets in endemic areas. Reduce breeding sites, standing water. Infection control. At-risk groups, laboratory workers, healthcare staff, and others exposed to blood, body fluids, or cultures from infected patients. Precautions. Healthcare workers should follow standard precautions for all patient care. Laboratory staff should adhere to standard laboratory safety procedures to minimize risk of exposure. Possible sexual transmission. Scientific findings. Oropouche viral RNA has been detected in semen and vaginal secretions. Cultivable virus has also been found in semen. Concern raises the possibility of sexual transmission, similar to what has been documented for Zika virus and Ebola virus. Current status. No confirmed cases of sexual transmission of Oropouche virus have been reported. CDC guidance. Patients traveling to areas with Level 1 or Level 2 travel health notices for Oropouche should be advised to take precautions to avoid possible sexual transmission. Thanks for joining us in this overview of the Oropouche virus. Though less known than dengue or Zika, its public health impact is rising and staying informed is key. This video is intended solely for educational purposes. It does not replace medical consultation or professional diagnosis. If you found this content helpful, please like, share, and subscribe to the channel to keep learning together about internal medicine and emerging diseases. Drop your questions or experiences in the comments, and remember, prevention starts with awareness. See you in the next video.